Good evening, everyone. Today is the 35th issue of this series 1 of our Environmental and Occupational Health DigiConnect webinars. And it's my great privilege to introduce both our speakers, Dr. Rajiv Kumar Jain, our Senior Vice President. He will be presenting on the COVID rapid updates. And another second speaker, guest speaker is Dr. Rayaz Ahmed. He is our old friend and he's Senior Consultant in Department of Hemato-Oncology with at Rajiv Gandhi Cancer Institute. And his topic will be immune thrombocytopenic purpura. So before we start, sir, may I request our President, Dr. Gajendra Kumar, sir, to give the welcome address.
Good evening, friends. I welcome you all to this our webinar of Delhi branch of IOH. And today we have got two speakers. Dr. Rajiv Kumar Jain, our Vice President, will be speaking on COVID update. And our guest speaker is Dr. Rayaz Ahmed. He is from Department of Hemato-Oncology and Bone Marrow Transplant, Rajiv Gandhi Institute, New Delhi. And he shall be speaking on immune thrombocytopenic purpura. So both the topics are important. And with these few words, I welcome you all to this program. And my special welcome to our guest speaker, Dr. Rayaz Ahmed. Thank you.
Thank you, President, sir. So this is the second webinar today, sir, in succession. First webinar was there from Mumbai branch, and that was a very lively webinar in which Dr. S. Natarajan, he is a renowned ophthalmologist, eye surgeon, and he delivered a guest lecture in that. And in addition to the continuity of the ophthalmic care during this COVID pandemic, he has given a lot of insight on how to keep ourselves positive, how to boost our immunity, and how to maintain our...
don't say COVID positive.
During COVID times, we should
we always be negative.
Yeah.
COVID negative.
During this COVID times, how to keep the continuity of this ophthalmic care. So that is also very important, and he is doing a lot of community work also. He's a great Rotarian, and what he said was that if you maintain your circadian rhythm, that is very important. If you are maintaining your circadian rhythm, if you are going to sleep by 9 or 10 o'clock and get up at 5 o'clock, then it will definitely boost up your immunity, because your systems will normalize and they won't be overexerted, and that will take care of your immunity. And immunity is a very important thing. And right now in ITP also, this is also an immune disorder. And since it is very important in this context, so we have requested Dr. Rayaz to deliver a talk on this this particular topic. So our first speaker is Dr. Rajiv Kumar Jain, our Senior Vice President, and he is giving weekly updates. But because he has been, he was under home isolation for getting home isolation treatment for being COVID positive, and he is now recovered. So we won't give him a lot of trouble, and we would request him to give monthly updates, rapid updates, so that we are regularly updated. Although he will be there every week for questioning, for any question and answers regarding this COVID epidemic. So this was a request from his side and from our side also, and I hope
right, quite right.
Yeah, that will give a lot of time and insight for us also. So Dr. Rajiv Kumar Jain, sir, you can start your presentation.
Good evening, friends, from AUHD Delhi. This being the last episode of COVID-19 EPID updates in the current form, that is the weekly format. But from next December onwards, we shall be only having COVID-19 EPID updates on the last Saturday of every month. Because I feel the pandemic has also evolved, and we are entering a new phase of COVID-19 epidemiology, not only in India and the world. First of all, I would like to little uh, have little sharing of my experience COVID-19 positivity, because there's a lot of learnings as I found through this process. When you get yourself diagnosed and then the whole process, what you experience and you experience the system also is very useful to share on this platform. I was diagnosed on September 16 of this month, and I'm today completing 12 days of my home isolation out of the 17 days that are stipulated by the concerned district magistrate of the district that I reside in my railway accommodation near Rajiv Chowk metro station of Delhi. Now, since I was tested in a railway health facility, I noticed immediately on being diagnosed and the report being ready, I got a SMS on my mobile number from the district magistrate's office of the district where I reside. Very accurate information and advice. Second, my Arogya Setu application, which I already been using, converted into red immediately. There was no gap at all. And it continues to be red. And it is working very fine. Every day in the morning, I'm getting without fail a telephone call from the district magistrate's office asking my oxygen saturation, my pulse rate and my temperature, and any other symptom that I have. And this happens every day for the last 12 days, and it continues without exception. In fact, there was a visit from the Anganwadi workers after a telephonic call from the concerned health center near my residence of the government of NCT of Delhi. And very regular. They came, they gave a pro forma to me to fill up for home isolation, which I did, and that got updated. Very meticulous follow-up by government of NCT of Delhi. I must appreciate this home isolation protocol being followed and how various wings of government of India, as well as government of NCT of Delhi, are following the COVID-19 positive patients in home isolation throughout their period of home isolation. I got my all viral markers tested, which were, except for one, were within normal range. Besides my complete blood count, liver function test, and renal function test. So the baseline data was available, and whatever advice my physician had given, I've been following. I had only two symptoms which I would like to share with you. One symptom was fever, and second symptom was slight giddiness while I was changing my posture, which was of very short nature and which I had never experienced earlier. So one typical symptom and one atypical symptom. In fact, that very symptom led me to consult the physician on Sunday, 15th of November, and the physician arranged for home testing for not COVID-19, but for dengue and rapid test for malaria. The NS1 testing was done on Sunday at my home. On Monday, since the results of both the tests were positive, were available, and they were negative. Besides my having got complete blood count report, which was not showing any lymphopenia or any derangement, I was tested for COVID-19 through RT-PCR, both naropharyngeal sample as well as oropharyngeal sample. And the report came, and mind you, it is RT-PCR. Report was made available to me within 6 hours. I was able to get it, and being the ICMR portal fully integrated, the entire ICMR, Arogya Setu, and District Magistrate Office simultaneously got activated within no time. So information technology does wonders in healthcare. And this is my personal experience. And this experience is continuing. I've completed 12 days of home isolation. So I would now continue with my presentation for COVID-19 EPID updates, the global, national, regional, and local. And at the end, a new inclusion is a video which you would enjoy watching for 2 minutes. That is regarding the mask. So let's go ahead with the journey of COVID-19 epidemiological updates for this week. Next slide, please. Before I start, I would like to apprise you that on 3rd December, 6 p.m., Zoom, kindly join Royal Society of Medicine COVID-19 series on Are Vaccines a Silver Bullet for the Crisis? And the speaker shall be the principal investigator at the Oxford Vaccine Group in UK, and she's a woman physician, Dr. Maheshi Ramaswamy. I shall be sending you the link to register. Please do not miss, because in this conversation, the Royal Society of Medicine President, Professor Roger Kirby, shall be discussing with Dr. Ramaswamy behind the scenes insights into the development of the Oxford vaccine and analysis of the global COVID-19 vaccine effort regarding safety, hesitancy, delivery, logistical factors in administering the jabs, and whether vaccines really pave the way for an end to the crisis. So do remember, 6 p.m., December 3, do join in this exciting conversation. Next slide, please. This is the coronavirus disease dashboard relating to WHO on cases only. And on the right side, I've arranged the cases reported 24 hours from highest to lowest on the right side, where the blue dash are there. You would notice that out of 7,53,000 cases reported in the world in 24 hours to WHO, 3,22,000 cases have been reported by United States of America, the most developed country in the world. And India reported 41,322. Brazil reported 37,000. Italy reported 29,000. Russian Federation reported 27,000. Germany reported 22,800. And United Kingdom reported 17,555. So you can imagine how dramatically every day the situation is changing in the world. The epicenter today is USA and the entire Europe, including Russia and the Western Europe. Entire Europe is in the grip of COVID-19. You will understand when I show you the figures of deaths during the last 24 hours in these countries. You would this figure is shown in newly reported cases in the last 7 days. This is reflected over here. 11,66,000 by USA in 1 week, 2,22,000 Brazil, Italy 2 lakh, Russian Federation 175,000, Germany 126,000, and UK 121,000. Most robust healthcare system is reporting these numbers. The best of developed countries are reporting these numbers. Cases cumulated total per million population. If the world is showing 7,800 per million population infection, India is showing 6,776. And USA, look at the USA per million population, 38,561. 38,561. And Italy, 24,900. Russian Federation, 15,100. Germany, 12,011. United Kingdom, 23,194 per million population. That is the infection, the extent of infection in these countries of the world, developed part of the world. Next slide, please. Now, this is a look at the condition of number of deaths reported in the last 24 hours. Just go on the right side where you see the orange figure. 12,511 total deaths in the world. 12,511, out of which 3,635 deaths have been reported by United States of America in 24 hours. 822, Italy, second position. Third position, Brazil, 691. Fourth position, Mexico, 645. Poland, fifth position. Sixth position, 498 by UK. Russian Federation, seventh position, 496. And India is at the 10th position in terms of deaths reported in the last 24 hours. And if you look at the scale of India, the size of India, the expanse of India, the diversity of India, they've only reported 485 in 24 hours. These figures, if you look at the column on deaths cumulative total per 1 million population, that gives you a better insight. 183 per million population is the global average. USA is 789. Italy is 874. Brazil is 806. Mexico 808. Poland 411. UK 840. UK 840. Russian Federation 264. And India only 98.7, when the global average is 183. So this puts Indian situation in the context of global 194 countries. This is what the governments of the world are watching. The WHO coronavirus disease dashboard every day, twice a day. Next slide, please. This is India. This is a snapshot of Indian COVID-19 in a day. The current position is 93.5 lakh cases, 1,36,000 cases, 1,36,238 deaths, 138.2 million tests, and 4.5 lakh active cases. In last 24 hours, 41,350 new cases and 486 deaths. Yesterday, we conducted 11.6 lakh tests. 7-day average was test positivity rate is only 4%. Cases growth is at 0.48%. Next slide. If I had shown you the snapshot, this is the detailed map of Indian states in terms of new cases, new deaths, tests, test positivity rate, and growth rates. If you look at the figure on the left, that light blue color, Maharashtra continues to report highest number of cases in our country. And Maharashtra is followed by Delhi, Kerala, West Bengal, and Rajasthan, besides Haryana and Chhattisgarh. Tests per million per day, Delhi is performing good number of tests. Karnataka is also performing, but Maharashtra is still not performing. It is Way down below, if you look at the figure on the green column, 724 is the Maharashtra average. West Bengal is also not performing. It is worse than Maharashtra, 457 only. Rajasthan is also bad, 403 tests only. They need to increase the number of tests. Unless they do that, test positivity rate will not come down. Sikkim, Himachal, Nagaland, Ladakh, Rajasthan, Delhi, Kerala, Manipur, West Bengal, Chandigarh are reporting high test positivity rate from 16 to 7.5%, stipulated at 5% TPR. 7-day average daily growth, highest growth is occurring in where? You don't expect Himachal to get 2.3% growth when India is reporting 0.5%, but Himachal is reporting today 2.3% daily growth rate in the last 7 days, 4 times of India. Rajasthan 1.3, Manipur, Haryana, Delhi, Mizoram, Kerala. So Himachal, Delhi, Haryana in the north, Mizoram, Manipur in the northeast, and Kerala in the south, and Madhya Pradesh, Ladakh, Chhattisgarh, Sikkim have to be on the guard in the days to come. And mind you, winter is progressing all across the country. Next slide, please. This is the trends in daily COVID-19 numbers at the national level. 4 graphs, 4 observations, daily cases, blue, daily active, orange, daily deaths, red, daily tests, green. Daily new active cases, 7-day average, have gone into positive territory after being in negative territory for 2 months. That's not a good sign. Dr. Harshvardhan earlier had said that we have capacity of 15 lakh tests, which has never been touched. We are still testing around 10, 11, max 12. We are not touching even 12 lakh every day, which we should reach 15 lakh. Next slide, please. This is daily new COVID-19 cases across the states. Daily new cases and 7-day moving average. Just look at the graphs and the trends. What do you see? Clearly, Rajasthan, Gujarat, Madhya Pradesh, Haryana, Himachal are all seeing major spikes in daily new cases. Rajasthan, Gujarat, Madhya Pradesh, Haryana, Himachal. Please watch these states in the days to come. Next slide, please. Now, this is an insight into, I'll show you 2 slides for Delhi. This is RT-PCR now takes up close to 40% of daily COVID-19 testing in Delhi compared to the 20% range it has been a month and a half back. If you look at the bottom dark blue color, that is a proportion of RT-PCR vis-a-vis rapid antigen test. So now it has gone up to 40% during the last 4-5 days. It has to go beyond 50%. Next slide, please. Delhi's average daily testing is still around 55, 60,000, which is lower than what used to be during its previous peak. And on November 15, the Chief Minister of Delhi had said Delhi would do 1 to 1.25 lakh tests per day. And it's been 13 days since then. We are not seeing the testing getting raised. If you look at the orange figure at the bottom, it is plateauing, it is not going up, while the test positivity rate is 9, 8, 9, 10, 11, 12, 13, 14, 15% in the last 1 week. Delhi's testing has to increase if the testing rate has to come down, because only then we will be able to isolate. If you do not know who is positive, how would you isolate? Next slide, please. This is test positivity rate across states of India. Nagaland test positivity rate is rising very sharply. We'll look at the figure on the right. Second, Nagaland is rising like a shoot up. It needs a lot more testing. Next slide, please. This is test positivity rate in Maharashtra, the entire trend from April till today. It is continuing to show 17% positivity. WHO benchmark is 5%. Next slide, please. This is Kerala. Test positivity rate is 9.61%. WHO benchmark is 5%. And look at the trend. If you look at orange figure, if you look at red figure, that's a danger mark. The purple horizontal line is the 5% mark. If it goes above, testing rate has to be doubled, tripled 4 times. Only then you will be able to contain and manage. Next slide, please. This is Delhi. Test positivity rate. If you look at the right side, it the blue portion, it is going up again. It was going down, 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 and then started going up, up, and up. Next slide, please. I would again like to remind all of you regarding the Scientific Committee on Epidemiology of International Commission on Occupational Health webinars, which I told you last week on December 9 and 11. December 9, diesel exhaust and lung cancer, 20-year saga, as a part of EPICO Lifetime Achievement Award by Dr. Deborah Silverman of the US National Cancer Institute. And on Friday, December 11, do not miss outstanding speakers and panelists, the global bests, the application of standardized tools to evaluate epidemiological studies for risk assessment, promises and pitfalls by Professor Jonathan Stern, University of Bristol, Dr. Chris Thayer of US Environment Protection Agency, Dr. Mary Schoberberg-Berrigan, International Agency for Research on Cancer, and Dr. David Savitz of Brown University. I've already sent you the link to register. It's free and you could register and then watch these two. On your WhatsApp in the group, I've sent already. I'll send it again. Next slide, please. So I will end this discussion with a video.
Wear a mask, wear a mask. Is this really much to ask? Tie some fabric round your face. Oh, it's the simplest of tasks. At the gym, at the store, don't treat it like such a chore. No, these mandates aren't malicious. All your theories are fictitious. Stop the lies, stop the fights. No one's taking away your rights. All the speculation makes me need a flask. Come on and read some data. All you masturbators, wear a mask, wear a mask, wear a mask.
It's a mask, it's a mask. Heaven's sakes, it's just a mask. Such a shame that asking folks to follow rules gets you harassed. You can shout, you can glare, but listen, Karen, I don't care. Never seen folks so dramatic over a f***ing piece of fabric. Hard to breathe, feels too hot. Quit your bitching, there's a thought. Suck it up, and don't you give me any sass. We've got a lot to do, and it's not just the flu. So wear a mask.
Wear a mask.
Wear a mask.
Wear a mask. Wear a mask. Wear a mask. Get your head out of your ass. Try to think of someone other than yourself is all we ask. While you sit watching Fox, ignoring science and the docs. Wow, your ignorance is showing as the death toll keeps on growing.
Case by case, test by test. Don't forget, you're not oppressed till we put this damn pandemic in the past. Try not to be so grouchy, have some faith in Fauci. Wear a mask, wear a mask, wash your hands and wear a mask.
Thank you so much. So we shall meet again with a new version of COVID-19 Epi updates on the last Saturday of December after Christmas. Thank you so much.
Thank you, Dr. Rajiv sir, for giving an overview of this COVID pandemic, sir. So this was a great insight on how the things are going on across the world, and especially in context of Delhi, where the things are not under control still, and gradually we are working towards controlling this pandemic across India. So a lot of insight has been given by you, and especially this video on masking and other COVID appropriate behavior, that is very important. And yes, we have been waiting for the vaccine, but vaccine will not be the ultimate solution. We have to still do all these public health measures that they should be in place, and we have to make a behavioral change to overcome this COVID-19 pandemic. So our second speaker today is Dr. Rayaz Ahmed. Dr. Rayaz Ahmed has been enlightening us on different topics. Earlier, he has in the issue 26 of our COVID webinar, this Environment and Occupational DigiConnect webinar, he has delivered on diagnosis and management of severe aplastic anemia on 19th September. And today also we have requested him to take a more relevant topic, that is immune thrombocytopenic purpura. And because this is also a immune system disorder, and because the disease sometimes follows the viral infection. So we would also like him to throw some light on post-COVID, this sequelae, or post-COVID, some complication which may lead to ITP. So what all things we need to monitor, especially the petechial hemorrhages or purpura or ecchymosis, if there is any in the, because the bleeding disorders, they are also very common in post-COVID patients, in COVID severe patients. So again, I would like to introduce Dr. Rayaz to you all. Just to introduce you, Dr. Rayaz Ahmed is senior consultant and in the Department of Hemato-Oncology and Bone Marrow Transplant at Rajiv Gandhi Cancer Institute, New Delhi. And Dr. Ahmed has been trained at CMC Vellore and has a special interest in stem cell transplant, bone marrow transplant. And he is having more than 10 years of experience in stem cell transplant, including allogenic, autologous, and matched unrelated donor and haplo stem cell transplant. He received training and fellowship in bone marrow transplantation from CMC Vellore, and he was ex-associate professor at CMC Vellore. And in his professional journey, a lot of achievements and awards are there to his credit. And he was credited with the start of multiple pioneer works in the field of hemato-oncology, and organized much training in this field at global level. And university gold medal was awarded to him in MD pathology in 2003 at Shivaji University, Kolhapur, Maharashtra. He worked as associate professor in the Department of Hematology at CMC Vellore, and performed 300 stem cell transplant at Rajiv Gandhi Cancer Institute and Research Center, New Delhi. Worked as principal investigator in many medical oncology hematology trials since 2010. And he did his DM in hematology from CMC Vellore and MD from Shivaji University, Kolhapur, Maharashtra. And he did his MBBS from Pandit Ravi Shankar University, Raipur. So this is a short introduction of Dr. Rayaz Ahmed, sir. Dr. Rayaz Ahmed, sir, you can share your screen and start your presentation. And Dr. Rayaz is one of the key persons whom we look forward whenever we are in trouble, or we require some help, or we require some advice, then he is always available. And Dr. Rayaz, sir, you can start your presentation.
Very good evening, sir, and thank you for the organizers again for having me here. And I wish everyone is safe, and please wear the mask. The only thing I think so in COVID is working is mask and the distance, as rightly said by all the distinguished faculty. Vaccine may not be the only solution. Let's see how it goes. Maybe one of the things we are looking forward, but everything pinpointing hopes on vaccine is not a good idea. So let's keep our talk to our ITP, and let's see. In this talk of ITP, I will see how we diagnose and what do we do to, and how we manage it. It's the basic approach to this topic of ITP. Next slide, please. Okay, so let's start with a case presentation. Okay, typical case presentation, almost everybody sees in their OPD, 41-year-old male reported to dental college and hospital with complaints of bleeding gums since last 2 weeks. Patient also known in a case of ischemic heart disease for last 7 years and has been on tablet of isosorbide atenolol and he has discontinued aspirin 6 months back. Most common, it can be elderly, adult, and we see this type of cases coming to us. Bleeding gums, mostly they will complain, okay, I thought it's due to trauma, then they will think some gun infection, and initially getting treated locally, maybe taking some form of dental cleaners, and then they visit to a physician. Next slide, please. Okay, and when we examine them, then we see, okay, apart from bleeding, they will have also some petechiae and purpuric spots. So he had this purpuric spots in the body since last 2 months, which he was ignoring. He had in the forearms, pedicle spots over the right arm, intraoral examination, bleeding from gingiva and lower anterior region, which was inflamed, reddish, tender on palpation and soft inconsistency. See, again, most of the time, patient, when they have bleeding, they tend to stop their brush. They say, okay, the more I will brush, the more it will bleed. I think so it's the other way around. We should always and always tell whatever is the cause of bleeding, you should always brush your tooth. It doesn't depend what your platelet count is. A soft brush once a day or twice a day is a must. If you don't brush, blood is a very good source of bacteria. Okay, so blood, the bacteria and the other organisms will grow and they will infect further. So by the time the patient present to you, they will have infected gums. Instead of having only bleeding gums, they will have infected gums. So sometimes we get carried away, okay, must be the local cause. So one request to the house is, whenever they have this bleeding issue from the gums, they should always ask patient to do the gargling and they should always do brush. Tell them that if they had post, it will go away. Not rigorous brushing, but soft brushes will be do. Next slide. Okay, so this case was again tested. LFT, ultrasound were normal, CBC which was done as it should be ordered in almost every patient. Hemoglobin was normal, 13.5, WBC 10,500, and the platelet count was less than 20,000. Next slide, please. Now, reasons of thrombocytopenia. So these are the few reasons which we have. Any patient with thrombocytopenia, we should always have is HIV testing, which should always ask for ANA. We should always ask for PTA, PTT, which can be, and we should ask for correcting studies. It may be difficult to have this correction studies locally, but PTA, PTT should be asked for. Drug ingestion history should be taken. H. pylori infection history should be taken. And also the CLD, chronic liver disease, is common. Also look for that. So how to do that? You always do an ultrasound after examination, get an ultrasound done. Look for your hepatic echo texture. Sometimes CLD may be the cause of thrombocytopenia. HIV presence can cause thrombocytopenia. Hepatitis C can cause thrombocytopenia. ANA positivity, then the diagnosis will move towards SLE, that always. But whatever the cause of thrombocytopenia, always ask for a bone marrow. Next slide, please. Okay, so apart from this, so this all causes has been ruled out. It was negative in our case. And next slide, please. So finally, he was labeled as ITP. So see, ITP, you don't jump to a diagnosis that, okay, his platelets are low, it's having ITP. No, you have to rule it out. See, there should be no lymph node, no liver, no spleen palpable. So if you have any liver issues, think some other causes. If spleen are palpable or both are palpable, some other causes can be there. Nodes are present, terms thinking of leukemia or SLE can be there. Next slide, please. Now, coming to ITP. So ITP is an immune-mediated acquired disease in adult and children. So in basic thing, it's a cartoon. We have been seeing this and reading about it. So what actually happens in ITP? In ITP, because of some immunological dysregulation, what happens? Our own protein is getting killed by another protein. I'll tell you in a little bit detail. So what happens is you get a viral infection, it goes and dysregulates one of our protein. So that protein start destructing its own self. That is autoimmunity. So that protein can be targeted to anything. It can be targets towards your joints, it can targets toward your lungs, it can targets towards your marrow. Suppose these targets, these antibodies, these proteins have got a target on their platelets, they will go and chew up the platelets. They will go and target, and our body spleen has got the filtering mechanism, it will got filter it. So in ITP, there is a huge production of platelets. Production is normal. There is nothing wrong with the production of the platelets. The production is being there. That's why they are surviving. But once they are produced, these abnormal proteins get coated on them, and that they are removed by the spleen because of this. So this is the basic pathology understand of the ITP. So ITP is characterized by a low platelet count, less than 1 lakh. If there are no other features, there is no HIV positivity, there is nothing SLE, no chronic liver disease, you label them, okay, they don't have this problem. Hence, the bone marrow was done. Bone marrow shows adequate number of megakaryocytes. The bone marrow will be reported by a pathologist like megakaryocytic thrombocytopenia. So the mother cells of platelets are megakaryocytes in the bone marrow. 1 megakaryocytes produce 5,000 platelets. So these megakaryocytes, presence of these megakaryocytes, the bone marrow says, okay, the production problem is not there. So megakaryocytes are there and they are producing the platelets. Only when they come to the peripheral blood, these platelets are being coated by the antibodies, and these antibodies are being tuned by the spleen. So next slide, please. Now, there are different definitions given for ITP, primary ITP, secondary ITP. In actual ITP, primary, that is autoimmune, you have got this autoimmune disorder characterized by isolated thrombocytopenia in the peripheral blood with less than 1 lakh platelet count in the absence of any other cause or disorders that may be associated with thrombocytopenia. Secondary ITP means the platelet count are low, secondary to some other infection, secondary to SLE, secondary to HCV or HIV, secondary to H. pylori infection, secondary to drug. So you have to take this account before you make a diagnosis of ITP. So we cannot do just CBC and say, okay, this is ITP. No, we cannot do that. We have to say, check all these parameters. When all these parameters are negative, you do a bone marrow. Bone marrow is also not showing any signs of. Why we do a marrow, we will discuss later. So these all things, and you label them ITP. Now, in ITP, there are different phases of the disease. So once you have diagnosed a patient of ITP, it's newly diagnosed. Within 3 months, it is called newly diagnosed ITP. Now the term acute has been taken off. Generally, we used to read acute ITP, chronic ITP. Now acute has been replaced with newly diagnosed ITP. From the diagnosis within less than 3 months, newly diagnosed ITP. From 3 months to 12 months, platelet count is low, then you say persistent ITP. These are the new addition in 2014. Now chronic ITP, when the ITP persists in a person, low platelet count persists in a person, and then it is called chronic ITP. If the bleeding is severe, then you have this bleeding manifestation, mucocutaneous junctions, then you say severe ITP. The term fourth, that is refractory ITP, is only when you have done splenectomy for a patient and that has relapsed again. So that is labeled as refractory ITP. Next slide, please. Now, incidence, again, this is all European and the US data. Incidence is 1.6 to 4 per million per year, and prevalence is around 50 per million. And as the age increases, you see, it's been increasing over a period of 30 to 93 per million, and from 18 to, in India, basically we see in less than 20 years, one peak is in that side, and another peak we see more than 60 years of age, more than 50 years of age, you can say. Between 20 to 50, the incidence is little less. Now, prevalence by male is to female, 40 to 60 in the Western data. Our estimate is also the same. Next. Now, immune thrombocytopenia in children, generally we see in when the season, this season, we see a lot of viral infections, and typically the patient will present after a viral infections, they will have eosinophilia in the blood and the platelets are low, and will be diagnosed over a period of time as newly diagnosed ATP, or previously it was labeled as acute ITP, which may or may not resolve spontaneously. If the platelet count may be 20 to 30,000. It depends on the pediatrician whether he will follow or he will want to give them steroids. A trial of steroids may resolve. So some patients will resolve, some patients may require treatment when the platelets are low or the bleeding manifestation. If you have that feeling that no patient might bleed, you start treatment. And 20 to 30% of the patient develops chronic ITP. It's as difficult as adults with then the case of chronic ITP is little tough to treat. Next slide, please. Demographics, as I told, in this is also again the British data, British Journal of Hematology. Again, they have got two models initially in the less than 20 years of age and again after 75. Generally, we see the same, less than 20, and again the rise increases there after 50 years of age. Indian data also similar thing. Next slide, please. Yeah, now coming to the clinical presentation. Next. Now, we know that when the platelets are low, mostly we see bleeds in the skin or mucosa. So if you have a pinpoint bleeding, not palpable, that is petechiae, you can see in the skin, it can be as severe. The whites, taken from cartoon, taken from the net, mostly the European and the Americans, they will have this white skin and you will be able to appreciate. In our dark population, sometimes it is a little tough to appreciate this petechiae. Purpura, little bit more appreciable, but generally it has all this petechiae has coalesced to form a big purpura. Wet purpura, it should be taken seriously. The dry bleeds you may ignore during a course of treatment, but when you are you have already diagnosed a patient or you have a newly diagnosed patient of ITP with wet purpura, that's a sign that he needs urgent treatment. The same with subconjunctival hemorrhage. If you have got conjunctival hemorrhage, you will have this, you know that the patient will require this treatment urgently. 1% of the patient may present to you as IC bleed, that the white color, the CT scan of the brain, you can see this bleeding is there. He will be requiring lots of steroids, may require urgent IVIG infusion, platelet increase, and your blood evacuation. Next slide, please. Now, the physical signs and symptoms of ITP can vary, as I shown in the previous cartoon. The most dreaded complications that we are very aware is that intracranial hemorrhage. Fatal bleeding occurs most commonly in adults with a platelet count less than 30,000. So 30,000, I will like to tell you that this is the hemostatic level of the platelets. If you have got platelet count of 30,000, more than 30,000, the chances that the patient will have serious bleed is almost nil. If you have got a patient with less than 30,000, you may worry. Less than 10,000, high likely to bleed. Between 10 and 30,000, depends on the clinical condition, if he has fever or any other. So look for the signs of mucosal bleed if in this range, 10 to 30,000. Above 30,000, generally patient is not going to bleed. So bleeding is one of the most common symptom of ITP. Purpura may appear on the extremities, and mucocutaneous bleed, nosebleed, heavy menstruation, and common gastrointestinal bleedings are common. Fatigue can be reported almost in 20 to 40% of adults, and 20% patients with ITP correlates with the platelet count with the less than a lakh. And steroid treatment, bleeding does not correlate with the duration of ITP, age, or gender. So thrombosis, no. One side we are talking of bleeding, another side we are talking of thrombosis. So it's the same as like we in the COVID side, like dengue, we see more commonly the hemorrhagic complications, but in this our corona patients, we are seeing more of a thrombotic episodes. We are wary of we are giving antiplatelets, we are trying to give the low molecular weight heparin to the patient so that they may not thrombose. The same way, ITP patient, mostly 99% of the patient will have bleeding, but sometimes you can get this venous arterial or combined thromboembolic episode, especially if they have this antiphospholipid antibodies, that is SLE associated with them. Next slide, please. Now, disease clinical features and disease course of ITP. As I told, chronicity, more than 12 months, so you leave it as chronic ITP. In pediatric, only 20% of the patient will have. Mostly they were curable. We say it's a curable. 20-30% of the patient will require long-term treatment. Adult, 50 to 60% of the patient will require long-term treatment. Only 40% of the patient will get resolved with initial steroids. In adult, it's a gradual over a period of time. In pediatric, it's sudden. Peak age of incidence is more than 50 years, and it's 2 to 6 years. Gender-wise, twice as common in females in adults. It's equal in the pediatric. Spontaneous remission in adult, 20 to 30% within 1 year, 80% within 1 year in pediatric age group. Preceding of infection is common in pediatric. Generally, they come after infection having some viral fever 2 weeks down the line. So one history will be there. Okay, the patient had fever 1 month back or 2 weeks back, and they will give history. But in adults, generally, we don't get this. Splenectomy was a preferred technique. The only curative treatment you can say in chronic ITP is splenectomy. We cannot cure ITP. We can only prolong the remission. Eventually, the patient relapses. The splenectomy was only curative in 70, but this splenectomy has now been over a period. With the advent of new medicines, splenectomy is being performed less and less over a period of time. Complete recovery is seen in 60 to 70% of the patient. In adult ITP, almost 90% of the patient in pediatric population will recover. Again, intracranial hemorrhage within 1.5% of the adults with ITP we generally see, and in less than 1% in pediatric population. Next slide, please. Next. Now, I summarized initially. So this is one electron microscopic photograph of megakaryocyte. This is the mother cell. This is the mother cell that is called megakaryocyte. These megakaryocytes have the platelets are being like shredded from the cytoplasm. So one megakaryocyte can produce in the range of 3,000 to 5,000 platelets over a period of time. Extended pseudopodia into the bone marrow, sinusoids, and released platelets. Each megakaryocyte of 1,000 to 5,000 platelets. Next slides, please. Next. So this happens when the platelets are being produced. They come to the peripheral blood, and they go. The lifespan of platelets in the peripheral blood is 7 to 10 days. After 10 days, they go to the spleen. The splenic macrophages chews them up. Next slide, please. Next slide, please. Okay, so what happened? So autoantibodies, so it can form, we don't know why they get formed. These autoantibodies, these proteins are formed because of some viral infections, some immunological, and these antibodies are directed towards the megakaryocytes and platelets. So these antibodies, these proteins get directed to the platelets and they get attached to them. And because of that, the body senses this, and the splenic macrophages try to remove that. That is called ineffective thrombopoiesis. Megakaryocytes and ITP maybe have abnormalities that leads to apoptotic cell death. Increased platelet destruction that bind to the platelets, and the antibody-coated platelets are opsonized and prematurely destroyed by the macrophages in the spleen and liver. That's the concept of splenectomy. So the spleen being graveyard of the this platelets, you remove the graveyard. That is, do the splenectomy, your antibody-coated platelets will be functional. Suddenly, your platelet count will rise from 5,000 to 1 lakh. So that is one of the emergency procedures. Suppose a patient is having an IC bleed, a known case of splenectomy, ITP, and having an IC bleed. So what you do, take him for the operation. You do the splenectomy. The moment you clamp the splenic pedicle, suddenly the platelet count will shoot up. And you will have, next 24 hours, you can see the platelets going in lakhs. That is the beauty of splenectomy. That was the concept, that platelets being destroyed in the spleen. If you remove the spleen, platelet counts will improve. So this was almost curative in chronic ITP. Next slide, please. Now in ITP, decreased platelet production or increased platelet destruction produce an imbalance that result in thrombocytopenia that I have explained. Next slide, please. Now, again, this you can understand now. Platelets are being formed, autoantibodies get coated, and this is increased risk. Again, the same cartoon. Next slide, please. And even the megakaryocytes, when they are coated by these antibodies, they get removed from the bone marrow. So you can have some platelet reduction, but not absence. You will not get megakaryocyte absent from the bone marrow. You can get little reduced. Next slide, please. Now, no compensatory increase in thrombopoietin production. TPO levels typically rise in the response to low platelet levels and stimulate platelet production. In patients with ITP, TPO level remains inappropriately low despite a low platelet count and platelet production. So it happens generally in aplastic anemia when your all marrow has been replaced. In that also, the marrow doesn't have megakaryocytes, the TPO levels are high. So, but in ITP, you have got megakaryocytes, so TPO levels are not that low. Next slide, please. Now, coming to the diagnosis. Next slide, please. Now, ITP remains a diagnosis of exclusion. You should never say that this CBC is showing low platelets, it is ITP. You can suspect, but it should be in your differentials, but not in the first. First, go for the common things. Go for the HIV, hepatitis B, hepatitis C testing. You go for this ANA testing. You rule out CLD. When all these causes one by one you have reduced, removed this. Sometimes sepsis, a patient can have fever. This sepsis can be there for a period of time. You can have this platelets returning to normal. Now, when the platelet count is less than 1 lakh, it's a threshold for the diagnosis. You cannot have more than, so we generally see in our lab reports, platelet count normal given 1.5 to 4 lakhs. 1.3 normal. Now, I will give you an example. If you have the patients from two areas, generally Jammu and Kashmir and from West Bengal, they will have something called on the smear giant platelets. Now, what is this giant platelets? So, when they will come with the CBC report and they will have typically platelet count of 70,000 or 80,000. So when you take the history, they will say, okay, I belong to this place. And you ask your pathologist friend to see the smear. They will say there are a lot of giant platelets seen. So in the Coulter machine, any particle of 2 to 20 femtoliters is being reported as platelets. So it can be a small RBC, the platelet, the chip in the Coulter machine, if any particle of 2 to 20 femtoliters, they will say it is a platelet count. Anything above 20 femtoliter, that will be flagged, that will be discarded. That will not be counted as platelets. That will be discarded by the machine. It has been designed in a sense. And any platelet count less than 2 femtoliter also will be discarded. So most of the 90% of the, say 95% of the population will have this 2 to 20 size, femtoliter size of platelet count. But these two areas, they have giant platelets. Generally, they have the platelet size more than 20 femtoliters. So hence, on the Coulter, their platelet counts are low. They get worried. They come to you. So don't start all. You may investigate fully. They say, okay, platelets are, megakaryocytes are normal in the bone marrow. All that things have, and they mostly get started on steroids. They get scared. Okay, I had some bleeding, and mostly. But if you find it, specifically from these two areas, you have got giant platelets are there. And the manual client, if you ask them, they generally above lakh. So do not start any treatment for them. Okay. So coming back to this patient and family history, physical examination. If you have got a spleen palpable, please get an ultrasound and ask the hepatologist to report on the echo texture of the, if it is CLD, then do a marrow to make sure everything is okay. CLD, you treat according to the CLD. Complete blood count, and it should be seen. The peripheral smear must be seen by a pathologist to be reported. And other lab investigations as discussed earlier. Next slide, please. So the same thing, also get the immunoglobulin levels done. Get the bone marrow should be the last one. Generally, we are very fast in ordering bone marrow. Bone marrow should be done. It's written. See, these are all American guidelines. So Americans can say, in India, if somebody asks this question, always I get from my friends, shall we do bone marrow or shall we wait? In India, the word that in the guidelines is that smear should be seen by expert pathologists. All pathologists are expert. But to see that ITP, you have to have a clinical history. Then you have to correlate with that. Sometimes doing a bone marrow is better. So even if you do a bone marrow, check. So in that case, you are missing on sometimes we get missed by the leukemia, especially ALL. So what happens is when the platelets are low and if you have not done a bone marrow and there are no blasts in the peripheral blood, the patient gets labeled as acute leukemia, especially ALL, and you start steroids. Steroid will mask this ALL, that blood cancer will get normal for a few months. And after that, they relapse again. So then the bone marrow is done and they will say, okay, blast was there, the back was done. So that's the reason we say Okay, in India, at least we have a consensus guidelines that, okay, we will do a peripheral smear examination, plus we do a marrow, just to rule out that we are not missing in anything else. And all these infectious markers and ANA, antiphospholipid antibodies, antithyroid antibodies, and pregnancy, all this, make sure that sometimes we get pregnant females with low thrombocytopenia because of the immune phenomena, anti-nuclear antibodies, CMV. If you believe that patient was giving the history of fever for last, especially in the pediatric age group, then it can be tested. Now, this is an unproven benefits. TPO generally don't do. Please don't go for the bleeding time or platelet survival studies or complement studies. First, basic evaluation must. Bone marrow must. In India, I will say it's a must. Next slide, please. Bone marrow examination, patient more than 60. See, these are all American guidelines. In here, if you say, if my kid getting an ITP, I'll ask for a bone marrow. Bone marrow is must. Relapsing after remission means you have given a treatment and patient has achieved remission, but again relapsed. You must do. Before going for a splenectomy, please go for it. Second line, when you're changing the therapy, please reconfirm that the production is okay. Hepatitis C, HIV, and H. pylori test should be done. Quantitative immunoglobulins test should be done to rule out immune deficiencies. Sometimes you will have viscohydride syndrome, and you have got skin that generally we see that platelet size is low. So sometimes viscohydride syndrome is misdiagnosed as ITP. So do for the quantitative immunoglobulins, go for the history, and you will get the diagnosis. Next slide, please. Now, this is again the cartoon showing it's a ITP is a diagnosis of exclusion. You should always have this TTP in your mind, DIC in your mind, probable bone marrow disorder in your mind, leukemias should be considered. Consider Evans syndrome, especially if you have got low hemoglobin plus low platelets and your DCT is coming, direct Coombs test is coming positive. Consider infection if you find atypical lymphocytes or you find neutrophilia. So CBC examination should not be only commented on the platelet, it should be you should have comments on the WBC series also. Neutrophil, how the toxic granules are there. You have got cystocytes in blood or NRBC in the blood. You should always have this viral test and DIC profiling done. Then if all these things are negative, then only make a diagnosis of ITP. Next slide, please. Now, treatment goals. This is the next part of this. Now, once the patient has been diagnosed, what do we aim for? We only aim for to stop bleeding. Generally, we say, I'm not here to increase your platelet count. Increased platelet will give me some confidence and the patient confidence. But always say, why this is important is, sometimes when you have started treatment, if you have started steroids, once you have diagnosed patient of ITP, you start steroids. Platelet will go to 2 lakhs. Over a period of time, it will come to 1 lakh. Then you will say, okay, this patient has platelet has dropping. I may increase the dose of steroids. Or if you have started tapering the dose of steroids, platelet may suddenly, you see it is coming. Again, you will start increasing. It's not correct. But I think so. Our aim is not to increase the platelet count. Our aim is to prevent bleeding or any toxicity from this treatment. So this is, we should keep in mind. In persistent and chronic ITP, avoid or defer the risk of mode or burden of some treatments such as splenectomy or immunosuppression for patients with persistent or chronic ITP. It is important to minimize adverse events associated with long-term corticosteroids. This is common problem. Means we have seen patients come to us, Cushingoid, they have taken steroids for 3 to 6 months. Cushingoid phases, he himself will be taking, sir, the moment I reduce my prednisolone from 40 milligram to 20 milligram, my platelets count starts coming down from 1 lakh to 80,000. Hence I have increased, or I'm taking that 40 milligram. They may be self-medicating once they know that steroid is working. That's not a good use. In refractory, achieve a platelet count sufficient to prevent bleeding and least amount. 20 to 30,000 of platelet in a post-splenectomy patient is good enough to carry on their life. That we should keep in mind. Next slide, please. Now, majority of the patients are asymptomatic. Majority, despite low platelet count. Increased mortality only with the patient with persistently low platelet count. Morbidity and mortality as such as complication of immunosuppressive therapy as from bleeding. So always keep in mind, when you start treatment, it should be short term. And you must have some specific period of treatment. When the treating doctor, he must tell how long I intend to continue this treatment. Next slide, please. So in treating adults, if you have less than 20,000, it's a must. If it is 20 to 30, it depends between your communication with the patient profile, comorbidity, all this should be taken in mind. When 30,000, only treat if there is a bleeding or it requires any surgery. Do not treat if it is more than 30,000. If the treatment schedule is over, I don't mean to say that you have, the moment it comes crosses 30,000, stop treatment. No, if you complete your one session, one course of steroids, if after that we can discuss this again. Next slide, please. Now, goal of the treatment in chronic ITP is to attain a hemostatic platelet count rather than a normal platelet count. But you should always have a good talk with the patient and the patient's relatives. Patient worry with anxiety about the disease burden, extent of bleeding, age, complications, accessibility to care, patient expectations, activity and lifestyle. This is a low platelets. They will have that I will bleed to death. No, it's not like that. They can have their normal life. They should be trained again and again. If you can have regular blood tests and come to you. But treatment, again, I'm telling, it should be specific. It should be time bound. It should not be continuous in nature. Next slide, please. So current challenges is maintain the platelet hemostasis and reduce the chance of bleeding. Who have failed the front line, platelet transfusion may cause coagulative complications. Immunosuppressants and splenectomy can address the mechanism of increased platelet destruction in ITP, but it cannot increase the production in vivo. Most patients relapse on corticosteroids when the dose is reduced, osteoporosis, opportunistic infection, cataracts, glaucoma, the long-term side effect. So what does it mean? Hemostatic means 30,000 above is the aim. If you are able to achieve that, that's more than enough. Never ever, once you have diagnosed it as ITP, do not transfuse platelets, even if the platelet count is less than 20,000. It's of no use. We generally do when it is severe bleed. Severe bleed we define like it has got an IC bleed. If it goes for severe nose bleeding is there, if it's got PR bleeding is there, then only you have got to transfuse. But that time the platelet has to be like 4, 5 SDP at a time, 2, 3 SDP. You get like the huge jumbo bags and get, so that you can, the funda is all the autoantibodies you get coated with the, will be coated by the platelets, and whatever the platelet productions are there, they will increase. It's not going to stop the antibody production. You are just coating those antibodies with this transfused platelets. Corticosteroids, again, it should be time bound. If you, these immunosuppressants, what we use in this treating, if you go on continuing, you will have these opportunistic infections and other side effects. Next slide, please. So this is the cartoon which shows we have got different where it works. So platelets, when it's being before it got into the macrophages, you say the corticosteroids, IVIG, anti-D, danazole, and even the chemotherapy vincristine will work on that part. Rituximab work on these platelets, decrease the production of this B cells, and hence these antibodies are not there. Azathioprine, cyclophosphamide, again chemotherapy. Sometimes we write this cyclophosphamide and patient will come, am I a cancer patient? Why I'm being given chemotherapy? So this cyclophosphamide is also immunosuppressants. We have to explain them, especially if I'm sitting in Rajiv Gandhi Cancer Institute. Vincristine, again, it is a chemotherapy, but this also works as an immunosuppressant, which works in ITP. Next slide, please. Next slide, please. This we have done. Next slide, please. Next slide, next slide. These are different bleeding scores. So WHO has given bleeding score, ITP bleeding scores are available online, and you can calculate what is the bleeding scores. If it is more, you can go for the treatment and you can have this given to the patient, and it will help us in starting or stopping the treatment. Next slide, please. Now, next slide, please. Now, next slide, please. The latest guidelines is by American Society of Hematology, 2000 guidelines, which is available online in Blood Advances. We can go through this. Next. Now, according to these, we have been, it's not much to it. Now, first is corticosteroid treatment versus observation. Second will be which corticosteroid type, and the second is the second line. And third will be the thrombopoietic agents. Now, these three I will discuss. Give me 10-15 minutes. I'll finish off the talk. The first, next slide, please. Once we have this diagnosis made of ITP, we generally start steroids. Next slide. So this is the same child person. That's what is your first line therapy of a newly diagnosed 33-year-old patient with bruising and petechiae. Okay, so and the platelet count is 7,000. There is no bleeding, and blood film is unremarkable. Basically, we are saying this is ITP. Bone marrow has been done. It is normal. We have done ultrasound. There is no chronic liver disease. HIV, HCV is negative. H. pylori is negative. We say it is ITP, nothing else. So, but platelet count is 7,000. It has come on a routine investigation. It has come to you and had some bruising and petechiae over last 2 months and has come to me. So patient may be very apprehensive when he sees the platelet count of 7,000. We will be apprehensive. Okay. So the house will be divided. Some doctors will say, okay, we will wait and watch somebody, but my choice will be to start on steroids. He's an active person. He's going outside. He's actively, the platelets are being chewed up in his daily activity. The chances of bleed. One course of, once you have diagnosed, first course of steroids, 1 milligram per kg for 3 weeks and taper over 6 weeks. That is the usual protocol we say. So patient of weight is 70 milligram. We start with 70 milligram of prednisolone, give that fully for 3 weeks and taper slowly over a period of another 6 weeks, 60 milligram, 50 milligram, 40, 30, 20, 10 and stop. That is the usual course of corticosteroids. Next slide, please. Next slide, please. So the question was, yes, once newly diagnosed, less than 20,000, less than 10,000, for sure less than 20,000, I will start the treatment. Look for this. But on treatment, if you have got mucocutaneous bleed, yes, I may look for 1 or 2 days, but skin dry bleeds, I'm not worried. But yes, wet bleed, I will be little worried. I may add another agent. But generally that doesn't happen. It may have second. You have to rule out some other things, whether is he taking any other drugs or not. So according to these guidelines, recommendation is among less than 30,000 point. We generally see the response at 7 days. If it is, generally you will get corticosteroid response by that. If it is not coming, you should counsel for the another, that it can be, if you continue for a longer period of the same steroid, it can harm him. You need to add another agent. Next slide, please. Same thing. Next slide, please. So next question is, what is your first line of therapy in the same patient? If there is no current bleeding, 7,000, prednisolone for 6 weeks, less than 6 weeks, or dexamethasone. So if it is, I'll go for prednisolone for initial 3 weeks and then taper over 6 weeks. Next slide, please. So this is the question, how long? So as I have been mentioning, that always decide the duration of the steroids. So we have this, whether you have to give for more than 6 weeks or less than 6 weeks. Next. Based on the following clinical experience and panel discussion, lack of evidence of benefit from long-term corticosteroid therapy, risk of harm and likelihood of adverse events are greater in more than 6 weeks of steroid, and there is no cost difference. So full 1 milligram per kg of corticosteroid for 3 weeks and taper over next 6 weeks. Usually do not continue this steroid more than 9 weeks of treatment in adults. Next slide, please. So side effect you have to keep when you are taking a patient on the steroid. Steroid related side effects will be there. We commonly know hypertension, hyperglycemia, sleep and mood disorders, gastric irritation, glaucoma, myopathy, osteoporosis, and weight gain. Next. Next slide, please. Next. This is the response we generally see at 7 days, response at 1 month, response at 3 months. Quality of life, we should always have that. What is the quality of life on steroid? Next slide, please. Next slide, please. Next slide. So short course, what we got it is short course of steroid, doses 0.5 to 2 milligram. Generally pediatric, we start with a 2 milligram per kg of steroids, adult 1 milligram per kg. In dexamethasone, generally we have, when we have this the bleeding is very high. So what we do is you start with 40 milligram kg of steroids generally in adult for 4 days and then just stop it. Okay, 4 milligram of 4 days of dexamethasone, 40 milligram per kg, or stacked dose of 40 milligram will be better. High per kg will be huge. I think so it's typing error. 40 milligram of this dexamethasone will be enough for 4 days and we can stop it. And we may get little bit better response than prednisolone. Initial better response. Next. Okay. So in the second line, once suppose 40% of the adult patients have generally respond to your initial steroid therapy, they will never ever receive this steroid treatment again in their life. But suppose if they don't respond or they relapse, so giving a low dose steroids is okay, but generally we need to add one more agent. So this is the question, second line therapy for same patient who had bruising, petechiae and oral bleeds, who was failed corticosteroid therapy, platelet count is 7,000, blood film is unremarkable. So our choices are rituximab, thrombopoietic agents, and splenectomy. Next slide, please. Now there have been lot of papers, lot of data, but not a single consensus. There are different studies. Some group will say rituximab. Again, rituximab can be given. This is an immunotherapy. It affects the B cell. B cell will halt the production of auto antibodies. Generally, we give weekly into 4 doses. Response rate is in the range of 40%. But long-term data, only 10 to 20% patient will benefit from giving rituximab. Short-term, 3 months, 40% of the patient will respond. Next slide, please. Next slide, please. Now, as I told, there's not much, so you can say randomized control trial. Only thing which have, the steroid works. Next line, rituximab, splenectomy, we have cyclophosphamide, we have got azuran, azathioprine, we have got dapsone works better, very cheap, it works. We have got paper from CMC, which says that, okay, using this dapsone may work, but these are all anecdotal reports. Some areas of the world will have some 300, 400 patient data. All this has been reported, can be used, but not much. So thrombopoietic agents has been studied recently, and it has come up, and it's the new thing in the ITP management is thrombopoietic agents. Next slide, please. Next slide. So what actually this thrombopoietic agents are? This is one is Altrembopag, one is romiplastine. So what the difference? No difference in the response rate. One is the Altrembopag, which is available in oral preparation. Romiplastine is available to us in generic form as injectable forms. You have to give 3 to 6 months of treatment. Generally, patient responds to either of them. If they have failed one, you can go to the other form of thrombopoietic agents, and generally we will have 50 to 60% of the patient responding in chronic ITPs. Next slide, please. Next slide, please. Next slide. Yes. So this is the summary of ASH guidelines. Short course of steroids are recommended over long-term steroids. Guidelines recommend the use of either prednisolone or dexamethasone. However, if rapid platelet response is required, as I said, especially if the patient have got bleeding, dexamethasone is recommended. Choice of second-line therapy depends on patient preference. Thrombopoietic agents like Altrembopag, that comes in the form of Revolade. Revolade is a little bit costly. 150 milligram tablets cost around 1,300 rupees, but assistance is available from the company. So even if given a course of 3 months to 6 months, 60% of the patient will be responding. We have got romiplastine injection. We have got one generic from the Intas, and that costing around 2,000 to 3,000, but it is given weekly, and you have to continue for 3 to 6 months. Again, 60% of the patient responds. Rituximab, the cheaper version, and when these things was not available to us, we were using cyclophosphamide, we were using azathioprine. Azathioprine, generally we use for 6 months to 1 year. Dapsone, generally 1 to 2 years, and they respond after that. So all this, mean to say this, all these immunosuppressants have their time defined. It cannot be you are going for life. When all these have failed, we generally go for splenectomy. Splenectomy works in about 70% of the case. That is the only thing curative, or because the advent of this thrombopoietic agents, all this patient splenectomy over a period of time has reduced, but still holds, if so, especially when this Revolade and Romiplastin has are not working. Next slide, please. Next slide, please. Next slide. Now, this is the what I mean to say. This has been the new things which has been come in the ITP. Next slide, please. Rituximab and splenectomy was there. Now it has come as the oral Revolade. Second options, initial response, rituximab 60%, but long-term effect is only, as I told you, 20%. Outcome is variable. Serious anaphylactoid reactions are there, but not much. Next slide, please. Next slide. Next slide, please. Next slide. Next slide. Second line, okay. This I said 70% people will respond, but the splenectomy has been declining in the Western data because of advent of these thrombopoietic agents, Revolade, and its access to the patient choice. Nobody wants to undergo the knife. If they have the oral tablets and it doesn't have long-term side effects, they can just continue these tablets or injectable Romiplastin, and things will be better. Hence, it's coming down. Next slide, please. Now, I won't go into detail. I will like to end this, that this new Ultrambo pack that is called Revolade, this is available. Only the side effects which we should be wary of, the liver function test, transaminitis is the major side effect of this. Sometimes we can see thrombosis, but these are all manageable. The only in India, we have the cost issues, but because the company have this patient assistance program, it's the chronic ITP. One of the best options to use is Revolade, and other is Romiplastin. With this, I will like to end my talk, and we can discuss if you have any questions. Thank you.
Thank you, Dr. Rayaz, for giving a deep insight of the topic. You have covered almost all the aspects with the starting from the diagnosis up to the management, the first line treatment and the second line treatment, and the latest what is available in order to manage this ITP. So if there is any question from the audience panelists, I would request first the panelists to take the question, sir. Dr. Gajen, sir.
My compliments to Dr. Rayaz Ahmed for such a beautiful presentation.
Thank you, sir.
On a very difficult topic. In fact, one small thing I wanted to ask, is it the same which we used to call idiopathic
yes, sir,
thrombocytopenic purpura?
Yes. It's the same as idiopathic thrombocytic purpura.
Okay.
It's same. Idiopathic is the same thing. Why should I tell you? We all know.
My compliments to you, Doctor. And with that, I have no question to ask. Thank you so much.
Thank you, sir.
Hello. I would like to ask you one question. Like you told that corticosteroid, they should be maximum. They should be given for 9.
Pardon, I couldn't get the question, Max.
Yeah.
Can you repeat the question, sir, please?
Yes. I would request all the panelists to keep their mic on mute, please. So, Dr. Rayaz, as you told that corticosteroid, they should be given for 3 weeks and then it should be tapered down over a period of 6 weeks. So, the maximum will be 9 weeks, of the corticosteroid treatment.
Maximum and, you can extend 10 weeks, don't extend beyond that. Basically, 1 milligram per kg for 3 weeks, and in adults, pediatric 2 milligram per kg for 3 weeks, and then taper over 6 weeks.
And the treatment goals specifically in case of ITP, it should be to stop bleeding, not to take care of the platelet count.
Platelet count, yes, absolutely.
And that will be through, like we will be achieving this hemostatic platelet count.
Yes. So hemostatic platelet count, 30,000, that's enough.
30,000.
30,000.
So if they are going below 30,000 and if we are having some mucosal bleeds, then we can...
Then you can, especially wet bleed, you can restart, you can give short course of steroids, 2 days, 3 days. But then if you are, suppose I have given a patient steroids, he has been in remission 50, 60, 70,000, more than a lakh, no issues. But suppose it has platelet count is around 25,000 and he has got a bleed. He has already received steroids. You can give a short course of steroids, but he needs second line treatment. You can opt for rituximab. You can discuss how is patient's ability. Suppose he's a worker, labor class. We know that his activity is quite full of muscular activity. The platelet consumption is high. If he gets some bruises over a period of time, he can bleed, he can get worried. So you can start him on second line. Rituximab will be costly option. Better option for him will be going for azathioprine or dapsone. So in this also, azathioprine and dapsone, these are little cheaper versions. You give for minimum of 6 weeks to 1 to 2 milligram per kg for almost 6 weeks. If you achieve a remission in either of these, continue for 6 months and then taper over another 6 months. So 1 year treatment in second line treatment. If the finances are okay, patients are okay for paying for rituximab, generally it's 50,000 per injection. 4 weekly doses will be enough. I think so. We can discuss with the family and you can give this. Again, these are momentarily increase. If patient understands that, okay, 30,000, 40,000, and he's very easily accessible, he can do the platelet CBC count at home and he has an easy access to the physicians, he can just wait and watch. If the platelet count is even 40,000, 50,000, doesn't matter. Suppose he want to go a patient of 40,000, persistent ITP or chronic ITP, platelet count is 50,000. He follows you fully and he says, I want to go for an emergency appendectomy operation, or he has to undergo some surgery. In that case, you may need to start him on so that platelet count at least go to 80,000 to 1 lakh. Generally, CNS surgeries will require 1 lakh of platelets. In that case, you need, okay, you tell them, okay, you have been giving this appendectomy, he cannot wait for that. Then, okay, you start him on steroids little bit, but start the second line. You can give IVIG to suddenly increase. The fastest is to give IVIG. 1 dose of IVIG, 400 milligram, 1 gram per kg, and for 1 dose, and within 24-48 hours, his platelet count will improve. He can undergo, or he has to undergo splenectomy. Otherwise, I think so 50,000 platelet count should be enough to manage his own life. There is nothing wrong in his lifestyle that prevents why to undergo unnecessarily under steroids or any second line if that requirement is not there.
Dr. Shanbag sir, would you like to?
Okay. Lovely presentation, Dr. Rayaz.
Thank you, sir.
Outstanding. And, you have refreshed our memories and made it a little simple for us. I don't have any questions, but it was great presentation.
Thank you, sir.
Thank you very much.
Thanks.
Dr. Shiva, sir.
Presentation. I have no questions. Thank you very much.
Thank you, sir. Thank you.
Thank you, sir. So, Dr. Rayaz, again, I would like to ask you, once you are given a course of 9 weeks of corticosteroids after tapering the dose, and the patient is okay. So, how frequently we can give this dose of corticosteroids?
This full, maybe once more, but at least have at least a gap of 3 to 6 months, but not more than that.
Then we should consider for the second line of treatment.
Second line, yes.
And especially in case of patients who can't afford all these things, then splenectomy will be the...
In India, yes, splenectomy is the one good choice. Generally, patients are still hesitant to go undergo splenectomy. But before that, we have options of azathioprine, which is cheap, and another is dapsone. That works better. You can say 20 to 30% of this chronic ITP patient will respond. So that is 1 to 2 milligram per kg. You have to monitor the WBC count doesn't drop too much, and minimum 6 weeks of these medicines. And if they respond to the treatment, continue for 6 months to 1 year, and then taper over 6 months.
Dr. Rayaz, another question, this etiology of this particular disease, they say that sometimes this disease follows the viral infection. So especially in this COVID situation, are there any studies going on whether this
very tough to say. COVID, as you know, little funny. I said there are two, I think, so two aspects. One, we see this virus like dengue fever. We mainly see it's a hemorrhagic side. Dengue hemorrhagic. We see bleeding complications. Patient come and bleed and bleed. It's just like DIC. And other side, we have got this corona COVID-19, which generally what we are struggling is the thrombosis issues rather than bleeding issues. So we are seeing until as the later stages, they go into DIC. So here we are using blood thinners, this heparin, rather than you say bleeding issues are not there. So it's basically the clotting problem is there. Steroids we are giving to reduce the inflammation of the lungs, and this low molecular weight heparin we are just giving to prevent this blood clotting. I think so. These are the two things which is coming up. In ITP, we know, as such, I have known that papers that, okay, COVID has caused ITP. Not much. I have not yet to see that, okay, Corona has caused this ITP. We generally see with other flu, generally post flu infections, influenza, CMV, Epstein-Barr virus, but not with Corona. I have not yet. I'm yet to see the report.
Okay. So, Dr. Rayaz, there are a lot of appreciation in the chat box.
Thank you, sir. Thank you very much.
Go through them, Dr.
I just try to make it simple. We could have gone on, but thank you. Let's make it as simple as that.
Yeah. So, the panelists, if they have any question, they can ask. Else we can conclude.
Hello, sir. This is Dr. Devi.
Yeah.
I would like to ask Ahmed, sir, is there a danger of continuous gastric bleeding or large intestinal bleeding in the patients of ITP?
Yes. So when ITP is there, you can get, especially if your platelet count is less than 10,000, you can have this gastric bleeding, or you can have large intestinal bleeding. It is not common, but you can get patients with this. Patient may have pre-existing piles. Patients develop an ITP, he's strained during defecation and he start bleeding. That becomes a source of bleeding. Patient had gastritis initially, he developed ITP, and this gastritis, that gastric ulcer became a source of bleeding. That can be the reason they have bleeding. The more reason when you have this mucocutaneous bleed, mucosal bleed, don't give oral steroids, give IV steroids for faster action. I'm not saying it will not cause dyspepsia. You will have, if you give dexamethasone 40 milligram IV once a day into 4 days, the response will be little brisk. You have to increase the platelet. At least your platelet count will be increased, and you are taking care of the hemostatic part. If you contact a gastroenterologist and he do a scopy and he will say, okay, you have got an ulcer, and most likely it is because of this thrombocytopenia. Your aim of the treatment is to, even suppose the platelet count was 8,000, even if you have doubled the platelet count, 8 to 16, your bleeding will stop. That is called response in ITP. So generally they respond. So first line, yes, go for steroids. If they have not responding, go for the second line in this type of bleeding. It depends from case to case. So you question that whether they can have bleeding, yes, they can have. Treatment will remain the same, but little bit aggressive.
Thank you, sir. Thank you very much.
So, to summarize, sir, Dr. Rayaz, sir, we have to keep a watch on the symptoms of the patient, the physical signs of the patient. And in the follow-up, we have to keep a watch on the CBC and the bone marrow. And whenever there is any bleeding episode, we need to control the bleeding rather than maintaining the platelet counts. And if we start the steroids, then it should be within like it should not be given for more than 9 weeks. And if after, even after the second dose of this corticosteroids, if the patient is not responding, we should go for second line of treatment or the third line of treatment, like with rituximab or eltrombopag, and ultimate treatment can be the splenectomy, which can cure the patient. So thank you, Dr. Rayaz, for giving us the details.
Just on the horse, sorry, just this second line treatment, do not use too frequently. Means do not use steroids if you have given within 3 months or 6 months. It depends. You can use low dose steroids. Don't give full 9 weeks if you have not responded. Second line generally change. We have got good options. Revolade is a very good option. We have got injection romiplostin. That is a very good option. Although a little bit costly, but they are very good options. Steroids try to minimize as much as possible. Steroids may be the cheapest option. Most of the patients may be poor. But if you are bound to give steroids for the second time, just keep it not even 9 weeks. Just try to keep it less than 4 weeks and promote them to take another second line agent. That's I would like to add.
Right. Thank you very much, sir. Dr.
Thank
Rayaz,
you, sir.
We have designed a certificate for you that will send you.
Thank you, sir. Thank you. Last I received. Thank you, sir.
Yeah, this will be the for the second. And I would like to thank all the panelists also for sparing their time, and especially all the seniors from across India, and especially our Delhi IUH members, especially Dr. Angela, who has come for the first time. Would you like to say something, Dr. Angela? Anyway, sir. So it was a nice presentation, sir, and we got a lot of insight about the whole problem. So we are thankful to you.
Sure, sir. Sure.
IUH.
Thank you. Thank you, sir. Thank you.
Thank you very much.
Thank you, and good night, sir. Good night. Thank you.
Good night.